Good evening, everyone. It is a pleasure to welcome you all to the second webinar of VERTICON, an exclusive initiative of the AIB India Academy. It is my pleasure to introduce our host, Dr. Neha Shrivastava. Dr. Neha is a distinguished consultant neurologist and vertigo and ENT specialist and director of the American Institute of Balance, India. With extensive expertise in vestibular disorders and neurotology, Dr. Shrivastava is also an esteemed member of several international professional bodies and currently leads RTKL Vertigo and ENT Clinic and RTKL Diagnostics and Polyclinic in Mumbai. So, welcome Dr. Neha and over to you.
So good evening, everyone. It is our pleasure to welcome you to the second webinar of our series VERTICON, which we started on 7th of December 2025, and we look forward to continuing it. This is the very first webinar for this year, and we look forward to many more sessions, which includes our esteemed international and national speakers from different parts of the world joining us to enrich us with vestibular disorders and to have their more experiences, which helps us to improve ourselves in handling the patient cases. Today we have Dr. Lakshmi, Dr. Vikram Khanna sir, and Dr. Richard Gans to share their expertise in this field. So with this, we start the session for the day. I have my co-host, Mr. Pinakin Munshi, who is my Vice President for AIB India, and we both will be taking you ahead with today's session. Over to you, Pinakin sir.
Yeah. Thank you, Dr. Neha. So starting with the first speaker, our first speaker for the evening is Dr. Lakshmi Patil. Dr. Lakshmi Narendra Patil is a consultant neurologist at Breach Candy Hospital Trust, Mumbai. She has completed advanced training, including a fellowship in movement disorders, and has extensive clinical experience in managing strokes, seizures, dementia, Parkinson's disease, myasthenia gravis, and autoimmune neurological disorders. She played a key role in developing the stroke protocol at Breach Candy Hospital and has a strong interest in complex neurological case management, research, and academic leadership. Dr. Patil is going to enlighten us on the topic of differentiating peripheral versus central vertigo, a practical clinical approach. Over to you, Dr. Patil.
Thank you, Mr. Pinakin, for such kind introduction. I'll just share my slides. Are you able to see it?
Yes, we are able to see it. Doctor, you'll have to switch to the presentation mode.
Yeah, thanks. Okay. So good evening,
Thanks.
everyone. We start with the second webinar today. So we dwell into this topic of differentiating central versus peripheral vertigo. So many times when a patient comes to your OPD or an emergency with symptoms called dizziness, the most primary thing that we have to do as a attending physician is to distinguish whether it's a central or a peripheral cause, because as dangerous causes like posterior circulation stroke can present with these symptoms as well. So with this context in the background, let's move forward. As we know, dizziness is a very common symptom. Every third person would have experienced this at least once in a lifetime. And mostly it's seen in between patients of age 50 to 60 years. And it is also the age when patients have comorbidities and can have neurological disorders. To begin with, in the earlier days, the diagnosis began with description of the symptoms, distinguishing it from as vertigo versus non-vertigo. But as we saw more and more patients, we realized that this is not helpful and at times could also be misleading. So there came, okay, so for any person presenting with an acute dizziness, should we do an MRI? But let me tell you, that is also not very helpful. And there are instances when there are strokes which are there but cannot be seen in the MRI. We'll see more about this in the further slides. So when a patient comes, they just tell you that they're dizzy, and it can mean many things. At Drachman and Harter told us it could be vertigo and non-vertigo. While this non-vertigo can be a large encompassing subgroup. It could be syncope due to orthostatic hypertension, low cardiac output, vasovagal syncope. It could be just imbalance because of cerebellar disorders, pyramidal disorders, extrapyramidal disorders, or sensory ataxia. And if it's persistent, we have also seen patients with anxiety, depression, and now what has been described as triple PD, where there is persistent postural perceptual dizziness, that patient continuously keeps feeling this dizziness. So as a challenge for a intensivist, physicians, neurologist, and an ANT specialist is to categorize this patient into their own subgroups, whether it's a syncope, vertigo, and which will help us further evaluate them. So now let us listen to the description of this patient who was admitted with so-called dizziness. The video is in Marathi. I'll try and translate it in English for all of you. So here this patient is trying to describe her dizziness. And if you would have noticed, so she's telling that she's feeling unwell. This lasts for 10 to 15 minutes. There are multiple episodes. She also feels like a blackout. She also feels spinning. So she uses almost every other descriptive word that we would want to use to distinguish it from vertigo to a syncope or other causes. So sometimes these descriptions are not very helpful. But what do we do further? History is the most important part here. We go and ask the family members. So let's listen what her son has to tell us. So here he is again saying the same thing. Everybody, the dizziness is equal to chakkar. It is equal to feeling spinning sensation. They keep repeating this word, but what do they really mean? So here the son is trying to tell us, see, he's saying spinning sensation, but what he has observed is adding to the history. He's saying that he's noticed some stiffness in her limbs. There's some widening of the eyes, and she becomes unresponsive with some clenching of teeth. And then she regains the consciousness within few minutes and has completely remembrance of all the event that has happened, which goes against a seizure. So possibly this was a syncopal seizure where the patient experiences syncope, leading to myriad of symptoms from spinning, blackout, stiffening of the limbs. And this patient was later diagnosed to have ill-sustained and recurrent ventricular tachycardias. So this is where we have to distinguish the patients complaining of dizziness from a usual vertigo. So what is exactly vertigo? It is not a diagnosis, it's a symptom. So patient complaining of feeling of disturbed or impaired spatial disorientation plus a false sense of motion, typically a spinning, is a vertigo. And with the newer studies and this, apart from vertigo, we have to also look for other symptoms like visual vestibular symptoms. So that is visual spinning of the surroundings, or oscillopsia, that is the shaking of the visual field that results from vestibular dysfunction. Dizziness, as we have said, it is a vague and a very broader term which tells you that there is disturbed or altered spatial orientation without any false sense of motion. And postural symptoms, where the symptoms of imbalance or dizziness are present only while standing or walking, and which are usually seen in neurological disorders. So by going deep into the history, we try to classify the patient's symptoms into one of these four categories: vertigo, visuo-vestibular symptoms, a broad dizziness, or postural symptoms. And once we have categorized, we go delve into more depth into the history, whether it is sudden in onset, very abrupt, there were no triggers, then likely it could be a stroke. Or was there a trigger? A sudden head movement or turning in the bed led to this vertigo-like sensation. It could be BPPV, or it could be gradual, progressive, or persistent, like seen in triple PD and Meniere's disease. Or the vertigo happened after a specific event, like seen in traumatic vestibulopathy. Then what is the periodicity? Is it occurring at episodes and in between which the patient is completely normal? Or it is a constant feeling of imbalance and vertigo with added exacerbations? So episodic are usually the BPPV, transient ischemic attacks, postural hypotension, and severe attacks of Meniere's disease, while constant vertigo and vertiginous sensations will be seen in vestibular migraines and posterior circulation strokes. What is the duration which the symptoms last? Is it less than a minute, like seen in BPPV or vestibular paroxysmias? TIS and vestibular migraines can last for a few minutes, while few hours and persistent will be seen in acute vestibular neuritis, strokes, and Meniere's. So this is how we classify our symptoms. And what are the triggers? Was there an obvious trigger? And it is reproducible. So every time they're doing the same thing, that they're turning to the right or left, which is triggering the vertigo, which could be seen in BPPV and can be redemonstrated by performing certain maneuvers. Or there is a constant vertigo which is getting exacerbated, like in vestibular migraine, which would be exacerbated by motion, smells, patterned visual screens. While patients are traveling in a moving car, they get this triggered vertiginous sensations. So this tells you to categorize your vertigo into a episodic or a spontaneous, a short duration or a long duration clinical syndrome. And the most important part, what are its tag-along features, which will tell you whether it is central or a peripheral cause. So in a TI or stroke, there may be associated dysarthria, diplopia, sensory loss, dysphagia. While with Meniere's, we would see tinnitus, ear fullness. In triple PD, a lot of anxiety would be present, and history of toxins and drugs is very important. In anti-epileptics, as we know, toxicities with phenytoin leads to vertiginous, vertigo, and imbalance. Recent use of antihypertensives would have led to the low blood pressure, giving to similar symptoms. We know aminoglycosides, specifically gentamicin, leads to vestibular dysfunction, and whether there was a trauma. Another important red flag signs like drowsiness, neck pain, headaches points us towards the central cause of vertigo. So let us look at this case. He was a 65-year-old man, came into the emergency saying that he's been constantly feeling vertiginous dizziness, which started about 5 days ago. They saw a local physician, was started on symptomatic therapy. This further progressed and he started to experience imbalance while walking. And then he decided to come to the hospital. So we can notice here that he's got gaze-evoked nystagmus towards the left. And now he has gaze-evoked nystagmus towards right. And it's persistent, non-fatigable. While we see here, these are classically what is known as flaps. He looks very dull while examining. And we tried to do his cerebellar examination. So he's also confused. We have to repeat the instruction 2-3 times for him to follow. So that is telling you that the cause is central. There is something more to this vertigo. And there is incoordination that can be demonstrated while doing finger-nose-finger test. And similarly, He had incoordination in his legs as well. So we knew this is classically a cerebellar syndrome. And when we took the history, the patient had a history of seizures. About 10 days back, the patient had a breakthrough seizure for which he was taken to a local hospital and was given a loading dose of phenytoin. And the doses of phenytoin were increased. And his phenytoin levels were more than 90. So the severe phenytoin toxicity. So going into the depth of history in patients complaining of dizziness is very important. So like we said, these are the dots. What is the symptom, whether it's vertigo, non-vertigo, how did it start, whether it's an onset, whether there are triggers, what are the associated symptoms. So these are all dots which makes no sense if we just take, but our job as clinicians is to gather this information and see what pattern they form and join these dots to see what is the pattern and try to narrow down the differential diagnosis. So each disorder which has symptom as vertigo have a certain pattern which they present. So we should be familiar with the common symptom patterns of the disorders like vestibular migraine, BPPV, Meniere's disease, vestibular neuritis, TI, and stroke, and practice ourselves to pick up these patterns while taking the history. So in vestibular neuritis, we know it is very sudden in onset with continuous vertigo lasting more than 24 hours, associated with intense nausea, very intolerance to head motions, and unstable balance. They may or may not have a history of prodromal viral infection and they have oscillopsia. While in vestibular migraine, these patients may have had headaches in the past, but when they get the vestibular migraine, the headaches may or may not be present. This is one of the very important factor. Patients presenting with vestibular migraine, at that attack, the headache being present is not necessary. They may just complain of feeling imbalance, which is triggered or worsened by head motions, visual patterns, which triggers nausea. And these episodes may last for a few minutes to up to 24 to 48 hours. As against stroke and TIs, they will be very sudden acute onset. They may present as isolated vertigo, but they will be usually associated with gross ataxia. The patient would not have ability to walk. There may be associated other symptoms like hearing loss, diplopia, dysphagia. While in Meniere's disease, we are all aware, it is episodic tinnitus lasting for hours, episodic vertigo with a progressive sensory neural hearing loss in the background. And this is a very interesting phenomenon of vestibular paroxysmias. It is an episodic vertigo lasting with head movement in an upright position lasting less than 1 minute, and multiple episodes are experienced in a day. This occurs due to emphatic stimulations of the vestibular nerve due to neurovascular compression. And triple PD, the constant subjective sense of dizziness. So if you examine a patient with triple PD, it may be completely normal, but patient is not confident and complains of constant dizziness. There may be associated a lot of anxiety, and they may have had a past remote history of any peripheral or central vestibular disorder. So we have recognized these patterns. We try to narrow our differential diagnosis into one of these important causes and try to now distinguish whether these were central or peripheral. So examination. The examination, however focused for vertigo, should never ever skip the vitals. We have to take the blood pressure of every patient complaining of dizziness and vertigo. I've had patients walking into my OPD giving classical history of an BPPV, and when you check their blood pressure, it is more than 220 with a diastolic of 110. So the description and history can sometimes be deceptive. So vital monitoring is the most important and should never ever be skipped. Just feel the pulse. There may be irregular pulse intermittently. And then narrow down your examination based on your history to rule out whether it's a central or peripheral cause using the Hint's test. This is one of the very sensitive and specific tests that can be done bedside that helps you to distinguish an acute stroke from acute vestibulopathy. But the major drawback that lies in Hint's test is that the person performing it is sometimes not very confident in his own findings. This is what the studies have found out. So to be more confident, we have to keep doing it again and again. And if we suspect BPPV, we have to do this Hallpike test. And a focused neurological examination is necessary. As I'm reinforcing, the patients may have some cardiac issues, syncope, a simple auscultation to look for aortic stenosis is essential. So let's see how the head impulse test is done here. So this is a normal, normally any patient, the vestibular apparatus pushes your eye towards the opposite side. So that means when you're looking, you move the head towards the left, your eyes will look towards the right. And this is how the head impulse test is performed. Yeah, so if you have noticed, we have to first relax the neck muscles by moving them side to side and give a very brief short jerk, not more than 20 to 30 degrees on the either side, and look for the movements of the eyes. And if you notice, she's able to fix the eyes to the patient's face or the camera, and they do not move when the head is moving. So this is normal head impulse test. So let us see this patient. So if you notice, there is subtle nystagmus towards the left, which had some torsional component. Yeah. So here when they performed the head impulse test to the left, it was normal. While they performed the head impulse test to the right, it was abnormal. So hit abnormal is reassuring. It tells you that the lesion is peripheral. Why? This is a lady who had a bilateral nystagmus and a head impulse test was performed. So we can see there is the head impulse test is normal. There is no catch-up saccade like what we had seen in the previous video. And this is concerning because head impulse test is normal if you see it and it is seen in central lesions. Then comes the nystagmus. So how do you look and examine the nystagmus? We have to look at the direction of the nystagmus, where is the fast component, and whether it is unidirectional. And we will understand this in more detail with the videos ahead, whether the nystagmus is inhibited by visual fixation and whether it is fatigable. So these are all characteristics of a peripheral nystagmus. As against, in a central nystagmus, it can be bidirectional. That means if you look to the left, the nystagmus is left beating. If you look to the right, it is right beating. It is pure horizontal, pure vertical, without any torsional component. And it cannot be suppressed by visual fixation and it is non-fatigable. So how much ever times you keep repeating it, you will keep seeing the nystagmus. Unlike in peripheral, if you keep repeating the maneuver, after 4 or 5 times, you may not be able to see the nystagmus with that great intensity or sometimes none at all. So let us see here in this video. So there's a left beating nystagmus. That means the fast component is towards the left. When he in the primary gaze as well as when he's looking to the left, while it is still left beating when he's looking towards the right. So it is a unidirectional nystagmus. In all the three gazes, in the primary gaze, in looking towards the left and in looking to the right, the nystagmus is only beating towards the left. So this is a very classical characteristic of peripheral nystagmus. While we look here, so she's looking to the right, the nystagmus is looking towards the right. It's non-fatigable. So how much of a time she's looking at right, it was still present. Now she's looking to the left, it is beating towards the left. So this is bidirectional nystagmus, and this is a sign of central nystagmus. And what do you mean by vertical nystagmus? A pure vertical nystagmus is also a sign of central cause. So this is a very sick lady admitted in the ICU with brainstem lesions. And we can see a downbeating fast nystagmus. And the third component of the hint test, the test of skew. This is done by performing the cover-uncover test. So let us see how the test is performed. So you have to cover one eye and then look at the movement of the eyes when it is uncovered. So in this man's, when the right eye is uncovered, we can see that the eye moves from down to up. While the left eye is uncovered, it moves from up to down. So there is hypometria in the right eye and hypermetria in the left eye. And presence of vertical malalignment tells you that the test of skew is abnormal and the cause is central. So the Hints test is a very, very important and a sensitive test to distinguish central from peripheral vertigo in an acute setting. And it is said to be abnormal if any one of the three is present. That is, the hit is normal, head impulse test is normal, nystagmus we saw is central type, that is, it is bidirectional, it is non-fatigable, and the test of skew is positive. While all of this three, that is, hint abnormal, nystagmus is peripheral type, and test of skew is negative. But to add and increase the sensitivity of the hint test, there is something called as hints plus. In hints plus, along with the hints test, we have to do hearing assessment, which can be done bedside by using a tuning fork or by just rubbing your fingers beside the ears. And if there is acute loss of hearing along with acute vertigo, it points towards mainly acute stroke in the anterior inferior cerebellar artery territory, leading to labyrinthine ischemia. And in this scenario, because the infarct or the ischemia is very small, the MRI may be normal. So this tells you that your MRI is not a 100% tool to distinguish your central from the peripheral vertigo. Or it could be an onset of labyrinthitis if it is peripheral type of vertigo along with acute loss of vision. So, acute loss of hearing, sorry. Then comes an added examination of truncal ataxia. How do you examine this? You ask the patient to sit unsupported, get up and try to walk. If the patient has mild imbalance while walking and is able to do it independently, it is grade 1. There is severe imbalance with standing and cannot walk without support, it's grade 2. And on standing if he is falling apart, it is grade 3. And higher the grade of truncal ataxia, higher is the chances there is a central cause or there's a stroke in the background leading to vertigo. So this, along with hints plus, improves the sensitivity of the picking up an acute stroke to almost 99%. So we know three things to do: the hints, the hearing assessment, and truncal ataxia to have high suspicion of diagnosing central disorders, versus if the history is suggestive of a BPPV or the peripheral examination is the examination hints is showing peripheral, we'll want to do a Dix-Hallpike maneuver. So this video tells you in short how to do it. We have a whole lecture on BPPV after this. So this is shown the Dix-Hallpike maneuver for the right. We have to do similar towards the left as well. While taking the neurological history and examination, we look for the red flags for the stroke, which can be acronyms as 4 dangerous Ds: diplopia, dysarthria, disequilibrium, and dysphagia. Like we just said, if there's severe gait ataxia, it is a red flag. If the patient complains of headache and neck pain along with vertigo, it is a serious red flag and can be suggestive of vestibular dissection. Acute unilateral hearing loss is also a sign of a stroke, unless proved otherwise. And if a patient has risk factors like hypertension, diabetes, ischemic heart disease, or past history of stroke, it puts the patient into a high risk category. So let's look into another case. This was a 48-year-old man who had a childhood history of right seventh nerve palsy, presented to the emergency with acute onset dizziness. He was working at his office and suddenly he started to experience spinning sensations with vomiting, and he had difficulty in getting up and walking. There was no tinnitus, no earfulness or viral illnesses in the past. On arrival, his BP was also quite low, and on examination, he had bilateral gaze evoked nystagmus. And when tried to make walk, he was unable to walk, but also his BP was low. So it was not very conclusive ataxia scenario, but presence of the bilateral gaze evoked nystagmus was a red flag sign. So we ordered an MRI to look for stroke, and this was his MRI, which was reported to be normal. There was no signs of any infarct on the MRI brain, while his angiogram was also normal. But we were sure, based on the clinical examination, that there has to be a central cause for this acute onset severe vertigo, and hence the patient was admitted to the ICU, was treated with antiplatelets, statins, and the MRI was repeated after 48 hours. And then we could see that the MRI was positive, and it was actually a stroke which was not picked up on the MRI on admission. So this is what I was trying to tell you, that MRI cannot be 100% foolproof in an acute care setting with an acute vertigo. So we have dealt with all the central and peripheral causes, how to approach. There may be various other non-specific causes that may lead to simple dizziness, like imbalance in the electrolytes, low sugars, the drug toxicities. And I have to highlight in the point that here that while asking for imaging in setting of acute vertigo, it is very essential that you ask for MRI and not CT brain, because CT brain is not sensitive to pick up early ischemias, especially in the posterior circulation, where vertigo is an important symptom. And an angiogram to look is very, very important, because the patient would have had TIA, which is a harbinger of a vertebral arterial disease and a sign of an impending stroke. And if we suspect there's some other causes, we order the cardiac monitoring test. So as we have seen here, the take-home message is the history is going to point you out whether it's a central cause or a peripheral cause. Go into the details of it. Try to identify the patterns in the history, identify the red flags for the acute stroke, and then focus your clinical examination to confirm your clinical differential diagnosis. And keep practicing the HIMSS examination, because though it is very sensitive in picking up, it is only when you are confident in your own findings, you will be able to apply it clinically. Thank you.
Thank you, Dr. Lakshmi, for an enlightening session. Of course, I know your work and you have been doing very well in neurology, but you have very well differentiated about the peripheral and central vertigo, and there's a lot to be taken from the slides that you have shared and your expertise also. So thank you so much for once again being on this AIB India's platform. And I mean, just take a step back and wait for our panel discussion. Okay, thank you so much.
Thank you. Thank you.
Over to you, Pinakin sir.
Yeah, thank you. So our next speaker for today is Dr. Vikram Khanna. Dr. Vikram Khanna is a consultant ENT surgeon and a vertigo specialist with over 25 years of clinical experience. He completed his MBBS with distinction in ENT ophthalmology and cleared both MS ENT and DNB ENT in the first attempt. He's attached to 4 leading corporate hospitals in Mumbai, has contributed chapters to reputed ENT textbooks in India, and is a regular invited faculty at state and national ENT conferences. Dr. Khanna is going to present on the subject Postural-Perceptual Dizziness. Over to you, Dr. Khanna.
Thank you, Pinakin, for those warm words. Is the screen visible?
Yes, doctor. You need to go into the presentation mode. Thank you.
Yeah, I've done that.
Yep.
Okay. So I'm Vikram Khanna from Mumbai, which is the financial capital of the country and also known as the city that never sleeps. Neha today has given me two challenges. The first challenge is the topic, which is hardly spoken of in India, at the most 5 to 7 minutes. And the challenge was that I would be speaking for at least 25-30 minutes. So I'll try to justify her confidence in my abilities. The second and the more important challenge is to be speaking in front of Professor Richard Gans. It's just like, Indian Ocean performing the opening act before the Beach Boys. I hope Dr. Gans will agree with me and will be sparing with me for any mistakes that occur. With this, I would like to start my talk. At the very outset, I would like to make it very clear that I am not interested in diagnosing patients with vertigo and its variants. Yes, you read it right. I'm not interested in diagnosing patients with vertigo and its variants. Why? Because I believe in healing those patients having vertigo and variants. And I dedicate this presentation to Dr. Prahlad NB, who's a very senior ENT surgeon from India, who has immense knowledge, has written books, and travels across various countries to operate. I think probably after our Prime Minister Narendra Modi, he has the most number of visa stamps on his passport. So let me begin. Brandt and Dietrich coined the term phobic postural vertigo, or PPV. Around that time, there was also an entity described as chronic subjective dizziness, that is CSD. So the Barani Society had proposed the term persistent postural perceptual dizziness, or PPPD, or triple PD as it is commonly known, which was adopted formally in the 2017 meeting. Triple PD is defined as a functional vestibular disorder that is characterized by fixed criteria concerning the chronicity of symptoms lasting at least 3 months with non-spinning dizziness. There are triggering factors and there are triggering diseases and illnesses. The new term not only subsumes all of its earlier syndromic names, but it also highlights the postural and the perpetual aspects which form an integral part of its clinical picture. So this is the Barani Society criteria for the triple PD dizziness, which is part of the classification of vestibular disorders. One or more symptoms of dizziness, unsteadiness, or non-spinning vertigo are present for more than 3 months or more. The symptoms last for prolonged periods of time but may wax and wane in severity, and the symptoms need not be present continuously throughout the day. The persistent symptoms occur without specific provocation but are exacerbated by the 3 factors of upright posture, active or passive motion, and exposure to moving visual stimulus or complex visual patterns. The disorder is precipitated by conditions that cause vertigo, unsteadiness, dizziness, or problems with balance, which include acute, episodic, chronic vestibular syndromes, other or medical illnesses, and psychological distress. When the precipitant is an acute or episodic conditions, the symptoms settle into the pattern of criteria A as the precipitant resolves, but they may occur intermittently at first and then consolidate into a persistent course. When the precipitant is a chronic syndrome, symptoms may develop slowly at first and worsen gradually. Symptoms also cause significant distress or functional impairment. And the last and the most important, that the symptoms are not better encountered by any other disease or disorder. Coming to the epidemiology, psychogenic dizziness accounts for around 20 to 25% cases of dizziness, rising to 60% with added instances of functional dizziness post a vestibular illness. The condition predominantly affects young to middle-aged individuals, that is in the 20 and to 50-year age group, with a significant preponderance of females. The patients with psychogenic dizziness symptoms predominantly have higher scores of anxiety, somatization, and depression than the patients with vestibular dizziness. Triple PD is found to be comorbid with psychiatric conditions, particularly generalized anxiety disorder, panic disorder, major depressive disorder, and somatoform disorders. Interestingly, vestibular dysfunction and anxiety can serve as each other's precipitants, with vestibular illness leading to maladaptive responses, primarily emotional, and persisting long after vestibular injury, while at times anxiety can influence sensory integration, making one more predisposed to dizziness. See, this is what happens when you speak in front of Richard Katz. Triple PD can occur after experiencing other forms of physical stress like mild brain injury, illnesses, and vestibular conditions like BPPV and vestibular neuritis, especially among patients with high anxiety and poor coping abilities. Coming to the pathophysiology, it is very complex and there are multiple etiologies. Contrary to the vestibular related pathologies, functional dizziness does not occur due to peripheral damage, but rather dysfunctional processing in the central nervous system. There are four major pathophysiological theories. The corticolimbic system dysfunction. Indovina et al. In a functional MRI study revealed that patients with triple PD showed dysfunctional connectivity between the brain regions involved in processing visual, vestibular, and emotional information, thereby underpinning that emotional processing systems and balance functions are intricately interconnected. The second theory is the visuo-vestibular mismatch. In patients with triple PD and functional dizziness, there is staggering mismatch in the sensory integration, visual integration particularly. The condition, denominated as visual dependence, causes patients with such conditions to be immensely vulnerable to environments rich in visual stimulations, such as those found at shopping malls, in moving traffic, and scrolling computer monitors, as noted by Bronstein et al. The third theory is the central sensitization with anticipation-related anxiety. Staab et al. Suggests that this anxiety-related activation not only serves to modulate perceptions, but also may get compounded by disrupting motor plans and vestibular spinal reflexes, thus sustaining postural instability symptoms. The fourth is the maladaptive post-vestibular compensation theory. In this, many patients with triple PD experience symptoms after an identifiable vestibular crisis, such as vestibular neuritis, BPPV, and post-traumatic brain injury. Popkirov and colleagues underlined that with triple PD and poor central compensation present, not only with bodily problems, but more particularly with severe difficulties in cognitive and emotional processing, profoundly influencing spatial and balance related information. So this is the table which compares the cost functions for postural stability versus fluid locomotion, where the variables are enumerated on the left. The next column shows standing, which is considered low risk. The third column is standing high risk, and the last column on the right is walking smoothly. If you wish, you can take a screenshot of this table. Coming to the clinical presentation. Symptoms in triple PD patients can persist over months and years and have varying intensities depending upon certain environmental, cognitive, and affective stimulus conditions. The subjective nature of symptoms, along with the inability to relate them to neurological or vestibular manifestations, creates difficulties in ultimate diagnosis and diagnostic related frustrations. Patients with psychogenic dizziness tend to describe their condition with indefinite and non-specific expressions. Examples include feeling lightheaded, feeling as if one's body is floating, feeling as if one is rocking, feeling as if one is swaying, and feeling as if one is not feeling part of one's surroundings. Well, sometimes when you consume more alcohol, you tend to feel such things, but don't worry, that is different. Apart from experiencing phenomenal spinning, patients with BPPV, Meniere's disease, and others with actual dizziness, patients with psychogenic dizziness describe something entirely different from what has been explained above. The crucial aspect is, however, that the disequilibrium in psychogenic dizziness does not relate to localization and quantification as expressed above. Another characteristic aspect is the inductibility under specific environmental conditions, which are referred to as situational triggers. These include crowded public places, closed environments, environments with dynamic visual demands, such as shopping malls, moving cars, scrolling messages, and places with increased demands for spatial localization. Such environments present higher demands to the visual processing system and act as inducers or exacerbators of dizziness in individuals with high visual dependence, which is not uncommon in patients with triple PD and its equivalents. Another significant symptom is postural instability, in which patients experience marked symptoms while lying down or with assistant, although not when standing and walking, and relative clarity when lying down or with support. This is proposed to be due to an inappropriate internal model of postural control, in which overcorrection by the CNS results in rigidity and poor postural movement coordination to compensate for the perceived instability. The difference between psychogenic dizziness and peripheral vestibular disease is the absence of true vertigo. There is no sensation of spinning, provocation with position change, and episodic pattern. Moreover, there are no physical findings such as spontaneous or positional nystagmus, ataxia, and hearing loss. The dizziness in such patients is more constant and subjective, lacking the pattern and course seen in organic conditions of vestibular disease. Another frequent feature of clinical manifestations is the somatic symptoms of anxiety. These may include palpitations, chest pressure, hyperventilation, nausea, epigastric distress, tremors, and profuse sweating. Such symptoms occur due to the intimate link present between the psychophysiological activation and vestibular perception, and at times it occurs along with cognitive symptoms such as fear of falling, catastrophizing, and anticipation of anxiety. The last characteristic is hypervigilance with respect to bodily sensations, whereby patients are continuously scanning their body state for evidence of disequilibrium or dizziness. The clinical picture of psychogenic dizziness is defined by its chronicity, unpredictability, absence of objective findings of vestibular dysfunction, and its marked relationship with emotional and environmental stimuli. The clinical interview, with its thoroughness and compassion, is still the mainstay of diagnosis, as many of these aspects may not be easy to identify with physical examination and testing. Coming to the diagnostic criteria, these were defined by the Committee for Classification of Vestibular Disorders of the Barani Society in 2017. As per the Barani Society, triple PD is established if one or more of its core symptoms, such as dizziness, non-spinning vertigo, and a sensation of unsteadiness, are present on most days for at least 3 consecutive months. The symptoms reported and faced by patients with triple PD are not episodic in nature, as they pose a sensation of near continuity or fluctuations and affect the patient's daily life tasks. The sensation of dizziness is generally reported by the patients as if rocking, floating, and unsteady, particularly increased stimulation by surroundings and visibility, particularly in crowded places and environments enriched with visibility. One of the characteristic symptoms of triple PD is over-presentation of symptoms in response to three conditions: upright position, actual or passive movement, and intricate or dynamically changing visual stimuli. All these exacerbations can be attributed to the disturbance in the visuo-vestibular intrication, which define PPD. The triggering event of triple PD is generally linked with the destabilization of the balance system, even if only temporary. This can be caused by conditions like vestibular system disturbances, serious medical conditions, or serious mental stressors. The initial condition of vestibular disease and or mental stress may be perceived as having disappeared, but triple PD patients fail in readjusting their postural and perceptual systems, and such patients continue with inappropriate responses to vestibular stimulation. This failure of compensational responses at the central level has been proposed to occur as a consequence of elevated anxiety, high visual reliance, and an increased alertness towards body signals. Coming to the differential diagnosis, it must include exclusion of an alternative medical or neurological diagnosis. The presence of dizziness, so characteristic of triple PD, cannot be better explained by any other competing vestibular, neurological, or psychiatric diagnosis. For example, conditions such as vestibular migraine, cerebellar ataxia, or major depression with somatic delusional symptoms ought to be considered and ruled out by clinical assessment and or further testing. Although psychiatric comorbidities such as anxiety and depression are not uncommon in patients with triple PD, patients with such conditions can still receive triple PD diagnosis, and patients with triple PD can concurrently suffer from these conditions or be maintained in those conditions. The criteria of Berenice Society describe that PPD is not a diagnosis of exclusion, but represents a clinical syndrome with identifiable triggers, characteristic course, and sustaining factors. The recognition of this condition has found uses in various therapeutic approaches, such as cognitive behavioral therapy, vestibular rehabilitation, and pharmacological treatment, focusing primarily on decreasing the patient's anxiety and encouraging plasticity. Additionally, sharper definition of diagnostic boundaries has improved interprofessional communication, specifically with regard to neurology, otolaryngology, psychiatry, physiotherapy, thereby providing patients with comprehensive care. Symptom duration and progress. The time course of dizziness is also very helpful in making a differential diagnosis. Vestibular-related conditions produce symptoms of paroxysmal, episodic, or sustained vertigo, depending on the condition. Contrastingly, psychogenic dizziness is typically chronic and constant, often reported by patients as occurring on most days and persisting for 3 months or more. The symptoms are also reported to be always in the background by the patients, although they can be precipitated by environmental and mood-related activators. Coming to the quality of symptoms and symptom description, the qualitative aspects of dizziness are another thing that make it distinct. Vestibular-related vertigo will always be described as experiencing true spinning or rotatory phenomena, either precipitated by position change or exacerbated by turning one head. Patients with psychogenic dizziness will, by contrast, present with vague and non-specific symptoms such as feeling as if one is floating or rocking or swaying, or feeling as if one is disconnected from one's surroundings. The aggravating factors. The organic vestibular symptoms are generally provoked or exacerbated by particular physical actions. Psychogenic dizziness, by contrast, is generally enhanced by environmental and or emotional stimuli. Such stimuli include crowded surroundings, enclosed spaces, places with high visual stimulation such as shopping malls, transit terminals, and high-stress conditions. The increased sensitivity to visual motion and crowded surroundings is an indication of enhanced visual dependence and distortion of the visuo-vestibular interaction, which is very characteristic of triple PD. The associated signs and symptoms. Patients with psychogenic vertigo do not share clinical symptoms of organic vestibular disease. They classically experience somatic symptoms of anxiety, such as palpitations, perceived dyspnea, chest pressure, tremors, and gastrointestinal distress, particularly in those with concomitant anxiety and/or panic disorder, respectively. The reaction to vestibular suppressants can also support differential diagnosis. Vestibular suppressors like meclizine and dimenhydrinate and benzodiazepines offer at least transient relief of symptoms of vertigo in peripheral vestibular disease. But in psychogenic dizziness, these treatments are generally of little or no value and can sometimes worsen the condition by either causing somnolence or increasing bodily vigilance. Additionally, their long-term usage can undermine compensations in the central nervous system and is not recommended in functional dizziness patients, respectively. Coming to the objective findings and function testing, one of the characteristic features of psychogenic dizziness is that there would be no objective findings upon clinical examinations and vestibular laboratory tests. The tests such as VHIT or cervical ocular VEMPs or vestibular evoked myogenic potential testing or computer dynamic posturography are bound to be either normal or non-specific in patients with triple PD. Coming to the clinical history and bedside examination, the key diagnostic tool in suspected cases of psychogenic dizziness is a thorough clinical history. Clinical features such as chronic non-spinning dizziness, exacerbation by visual complex surroundings, and relationship with emotional distress, anxiety are suggestive of triple PD and its equivalents. Particular care must be taken with regard to language-related symptoms such as floating, rocker, disconnect, and temporal characteristic of the symptoms, including positional and situational precipitation. The absence of true vertigo, tympanic symptoms such as tinnitus and hearing loss, and absence of positional precipitation can exclude peripheral vestibular pathologies such as BPPV and Meniere's disease, respectively. The physical examination can be normal in patients with psychogenic dizziness, although pointers may include postural rigidity, exaggeration of the startle response, and avoidance behaviors. The neurological examinations, including cerebellar examination and observation of the patient's gait, must be normal and can thereby rule out central causes of imbalance. Provocation tests such as the disc Hall-Pike test and the head impulse test can be used to rule out positional vertigo and vestibular dysfunction. Coming to the laboratory vestibular testing, the video head impulse test, caloric testing, vestibular evoked myogenic potentials, and posturography. Assessment of the postural sway and sensory integration in various standing conditions. Patients with triple PD can present with increased sway velocity and/or increased visual dependence without evident vestibular dysfunction. So on CDP, the pattern 3 sway is diagnostic of triple PD. Coming to neuroimaging, the role of neuroimaging is not needed in suspected cases of triple PD unless there are typical neurological presentations such as deficits and progressive symptoms or new onset headache. However, neuroimaging may be required in the initial assessment to rule out certain central nervous system causes like vestibular schwannoma, cerebellar infarction, multiple sclerosis, and Arnold-Chiari malformations. MRI scan of the brain with an internal auditory canal protocol. I repeat, MRI scan of the brain with an internal auditory canal protocol is the investigation of choice. The findings from the functional MRI analysis revealed changes in the insular cortex, the anterior cingulate cortex, and the temporoparietal junction region activation in patients with triple PD. Coming to the psychiatric and psychological assessment, owing to the major link between psychogenic dizziness and psychiatric comorbidities, psychological testing has emerged as an integral part of the diagnostic process. Psychological testing can be started with the help of the following tools: GAD-7, PHQ-9, and MINI. You also need to exclude other causes before arriving at a diagnosis of psychogenic dizziness, because it is crucial to rule out potential medical conditions that may present with symptoms of chronic dizziness. A thorough cardiovascular evaluation, metabolic and endocrine disorders, medication management, especially polypharmacy, because it involves sedatives, antihypertensive, vestibular suppression, which can contribute to persistent imbalance or lightheadedness. Now, the approach to psychiatric assessment should be structured, empathetic, and integrated seamlessly into the overall clinical evaluation. It is important to avoid suggesting to patients that their symptoms are imaginary or just in the head, as such language can lead to disengagement or stigma. The screening tools. Initial screening can be efficiently performed using brief, validated instruments that assess anxiety, depression, and somatic distress. These include GAD-7, PHQ-9, PHQ-15, and the Dizziness Handicap Inventory. These questionnaires are self-administered and easy to incorporate into routine outpatient visits. High scores should trigger more detailed psychiatric evaluation. The structured clinical interviews. For diagnostic clarification, especially in the complex or treatment-resistant cases, structured or semi-structured interviews administered by trained clinicians are recommended. These include MINI and SCID-5. The psychological features to explore in the interview are anxiety sensitivity and anticipatory anxiety, panic attacks, health anxiety and somatization, depressive symptoms, and functional neurological symptoms. Coming to the management strategies for psychogenic and anxiety-related dizziness, the optimal care and management of psychogenic dizziness, such as those with triple PD, would involve a multimodal and multidisciplinary approach with respect to its physiological and psychological aspects. This individualized approach would be tailored according to each patient's symptoms, concomitant psychiatric illness, and impact of disease on functioning. First and foremost is patient education and reassurance. I don't need to elaborate much on this. It is already known. And this is for any and every condition that we treat clinically, whether it is dizziness or vertigo or any surgical illness, any medical illness, any cancer illness, or whatever. Second comes the cognitive behavioral therapy, or CBT. One of its main advantages in the context of triple PD is the ability to target maladaptive beliefs, avoidant behaviors, and anticipation-related anxiety that fuel each cycle of symptoms. The main constituents of CBT include psychoeducation, relaxation, activation, and cognitive restructuring. Third is pharmacotherapy, the mainstay for us ENT surgeons. Pharmacological management is most effective in patients with comorbid anxiety or depression of moderate to severe symptoms at time of presentation. The first-line drugs include selective serotonin reuptake inhibitors, that is the SSRIs. These are sertraline, fluoxetine, and escitalopram. And also the serotonin norepinephrine reuptake inhibitors, the SNRI, which is venlafaxine and duloxetine. The proposed mechanism of these drugs is modulation of the serotonergic and the noradrenergic pathways in the brain areas, such as the amygdala, insula, and the vestibular nuclei involved in the emotional and sensory processing and autonomic functions. Notably, SSRIs also decrease visual interdependence and central vestibular hypersensitivity, which are key pathophysiological constituents of triple PD. Staab et al. Found that the symptoms of anxiety and dizziness, severity and frequency were improved by SSRI treatment, that is sertraline, fluoxetine, and escitalopram. The therapeutic response is typically slow, with marked improvement achievable only after 6 to 8 weeks. The presence of early adverse events do not necessarily portend poor therapeutic outcomes. Patient-provider discussion may allow improved adherence and outcomes. So this is the dosing strategy that is used for the medications. If anybody wishes to take a screenshot, they can do so. Okay. Now coming to vestibular rehabilitation therapy or VRT, it represents an organized exercise-oriented approach intended to promote balance, fixation, and functional mobility. Despite VRT's original application in organic vestibular disease, its application and benefits can be significantly seen in patients with functional dizziness, especially those with sensitivities to motion, postural instability, and visual vertigo. It generally involves habituation, postural control, dynamic gait, and visual vestibular integration exercise programs. VRT in triple PD works by gradually re-exposing patients to movement stimuli and visual environments, thus reweighting inappropriate sensory processing. Patients with visual over-reliance or avoidance behaviors can greatly benefit from VRT that utilizes visual movement or pattern backgrounds. Evidence has shown that VRT can be effective in improving symptoms of dizziness as well as overall functional performance. Additionally, multimodal interventions incorporating VRT and cognitive behavioral therapy or any form of psychotherapy have been shown to provide better outcomes than single modal interventions. This is possible due to comprehensive collaborative efforts by physiotherapists, clinical psychologists, and the otoneurologists to progressively adjust exercise tolerance based on symptoms and mental preparedness. The fifth strategy is mindfulness and stress reduction techniques. Mindfulness interventions offer alternative strategies in dealing with autonomic dysregulation and emotional reactivity, which can be seen in psychogenic dizziness. Yoga, abdominal breathing, progressive relaxation, and mindfulness-based cognitive therapy have shown success in decreasing the sympathetic overdrive, emotional regulation, and increased interoception. MBCT specifically has combined mindfulness and cognitive approaches and has shown its effectiveness in relapse prevention amongst patients with depression and anxiety. Analyzing MBCT and its application in functional dizziness, it can be seen that MBCT can help patients disengage with rumination cycles, reduce fear of bodily experiences, and enhance non-judgmental awareness. Such interventions may be added to standard treatments or be used as initial approaches in patients with reservations against starting drug and or psychotherapy. So this is the table that shows the symptom and the rehabilitation therapy or the treatment option that could be most beneficial. If you want to take a screenshot, you can do so. Now coming to special populations in psychogenic and anxiety-related dizziness, the elderly patients. There is increased sensitivity to the aging of the vestibular system. There may be cerebrovascular insufficiency. There is sensory paresis, particularly visual and proprioceptive deficits, multiple drug interactions due to polypharmacy. As far as therapeutic approaches go, those focusing on gentle vestibular rehabilitation, cognitive and behavioral therapies, and mental support are shown to be particularly effective. Children and adolescents are the other subset. Adolescents, particularly females aged 12 to 18 years, are shown to be vulnerable to functional dizziness triggered by psychosocial disturbances such as academic pressure, relationship conflicts, bullying, or performance anxiety. Children show psychogenic dizziness often in combination with migraine and vertigo, benign paroxysmal vertigo of childhood, and functional neurological symptoms formerly submused under conversion disorders. The management should include psychoeducation of the patient and the family, school accommodations, and referral either to a cognitive behavioral therapies or other form of effective interventions which are available at mental health services that treat adolescents in particular. The saying is, prevention is always better than cure in any type of illness, and triple PD is no exception. So relapse prevention in psychogenic and anxiety related dizziness is a definite entity and can be achieved through patient empowerment through psychoeducation, maintaining behavioral activation, regular psychological follow-up, continuation of pharmacotherapy, ongoing vestibular rehabilitation therapy, stress management and mindfulness practices, relapse action plans, and self-monitoring. Developing a personalized relapse prevention plan empowers the patient to recognize early warning signs and intervene proactively. Such a plan may include identification of the triggers, a list of coping strategies, contact details for healthcare providers or support networks, schedule check-ins or diary entries tracking symptom patterns and mood. Self-monitoring tools like mobile apps and symptom trackers can enhance insight and facilitate timely intervention if a relapse occurs. Now coming to the last part, the recent advances and research directions. First is neuroimaging and functional brain connectivity. A functional MRI analysis by Indovina et al. Found that there is hyperactivation of the visual motion processing areas along with hypocortification of the vestibular processing networks in patients with triple PD, thereby giving insight into its neurological, neurobiological underpinnings. Furthermore, resting state functional MRI analysis have shown changes in default mode network connectivity in patients with triple PD. Autonomic dysregulation and biomarker studies. It has been observed that there is an increased salivary cortisol secretion, especially in early hours of the day in patients with triple PD. HRV levels are also postulated as a potent biomarker. Virtual reality-based therapy. Virtual reality has recently emerged as an innovative approach in rehabilitation of patients with functional and vestibular-related dizziness. Although it is still in its experimental stages, VR technology has the potential in becoming an effective and affordable adjunct to traditional vestibular and cognitive therapies. Artificial intelligence. Who can remain untouched? Not even triple PD. So AI tools could eventually assist clinicians in reducing the diagnostic delay, avoiding unnecessary investigations like MRI caloric testing, tailoring the rehabilitation protocols, and identifying high-risk patients for relapse or treatment resistance. Now, also we are seeing some other alternative modes of therapy like galvanic vestibular stimulation. It is non-invasive. It utilizes weak electrical currents delivered via electrodes placed on the mastoids behind the ears, and the currents have the potential to stimulate various functions within the vestibular symptoms, especially those related to balance, posture, eye movements, and spatial orientation. Emerging evidence suggests that GVS might also influence emotional regulation. Transcranial direct current stimulation, that is TDCS. It is another non-invasive brain stimulation technique that delivers a weak constant current to specific areas of the scalp through electrodes. Im and colleagues treated 12 patients with triple PD using TDCS applied to the left dorsolateral prefrontal cortex for 20 minutes for 5 times per week for 3 weeks. The results are mixed and are still being analyzed in a greater way. Iren and colleagues treated 16 patients for 4 weeks with non-invasive vagal nerve stimulation, scheduled twice daily and when needed for symptom flares. Patients experienced statistically significant improvement in the quality of life, and coexisting depressive symptoms, but had limited improvement in triple PD symptoms. Axer et al. Investigated the effectiveness of 1 week intensive program combining vestibular rehabilitation with various interventions like specific physiotherapy exercises to improve balance and functions, CBT-based psychoeducation, and group therapy to address unhelpful thoughts and behaviors related to dizziness using CBT principles. Jacobson's muscle relaxation training to reduce the muscle tension and anxiety potentially contributing to dizziness, and educational sessions to provide patients with information about dizziness and its management strategies. The VR here is virtual reality, not vestibular rehabilitation. I'm sorry for that. Kuwabara et al. Investigated a program combining acceptance and commitment therapy called ACT, a form of psychotherapy with virtual reality. Herdman et al. Introduced INVEST, a program combining virtual reality with CBT, specifically tailored for dizziness. INVEST provided therapist support and a patient manual for guidance throughout the program. Compared to standard VRT, INVEST demonstrated greater improvements in dizziness handicap and some aspects of psychological well-being also. Also, it is important to note that the standard treatment of triple PD, as highlighted in Zhao et al. Study, can yield positive results. The standard treatment typically includes medications, SSRIs, and virtual reality with various components targeting eye movement adaptation, balance, alternative training, and gradually increasing functional activities. Interestingly, even without additional interventions, patients in this study experienced reduced dizziness handicap, reduced anxiety, and reduced depression symptoms, along with improved balance. So sometimes simple things work very well if done in proper way. A big thank you to all those awake and who were all ears. Hope I didn't spoil your weekend mood. Thank you.
Sir, thank you for an excellent session on 3PD. Always an holistic approach. Treating 3PD requires only two things: patience from the patient. So basically, it is a lot of patient ears to listen and a lot of patience for the prognosis of the patient. So basically, I always say 3PD requires 3P more from our end. And also, an excellent session. You have covered every aspect of it, right from the triple PD to the anxiety and the various methodology. Only one thing I can say, this is the one of those factors where you require an holistic approach, because any one episode of vertigo can also become 3PD based on the environmental stressors or the factors affecting the patient. So thank you, sir. Please step back, sir, for the panel discussion. And Vinayak, you can play the short video before we take Dr. Gan's lecture for the day. Yeah.
Now I think we come to the most distinguished speaker for the evening, Dr. Richard Gans. Dr. Richard E. Gans is the founder and senior advisor of American Institute of Balance Global. He's based at Florida. He holds a PhD in auditory vestibular physiology from the Ohio State University and has over 20 years of experience in developing vestibular evaluation and rehabilitation protocols and techniques. Dr. Gans has served as president of the American Academy of Audiology, holds adjunct professorship at Nova Southeastern University and the University of South Florida, and he has presented over 150 academic programs worldwide. Dr. Gans will today share his insights on the topic Benign Paroxysmal Positional Vertigo, the trends for 2026 and beyond. I now hand over the stage to Dr. Gans.
Hello, everyone. It's winter in the United States. I've got a little bit of something, so I apologize for my scratchy voice. But I want to thank Dr. Neha for this wonderful invitation. She is near and dear to my heart and is doing great work globally. I also want to commend Dr. Khanna as well as the other presenters on their excellent presentations. So let's go ahead and bring up our presentation.
So just a few words to highlight. It's a pleasure having you on the first session for the year. And it is always good to share the platform with my guru, Dr. Richard Gans, on this. So thank you so much, sir, for joining in for this lecture. It's early morning from US.
Let's get the screen ready to share. There we go. Okay, everyone, you can see this now?
Yes, doctor.
Good, okay. So, first of all, we've known about BPPV since 1921, when Barony first published a paper on it. However, it wasn't until 1951 that Dixon Hallpike published some assessment protocols. But then it wasn't until about 1991 that we began to understand that you could treat this with gravity. And remember, it's important to understand what happens with BPPV. BPPV is otolithic debris exclusively from the utricle that disperses in the other canals, posterior, horizontal, and anterior. It can be in one ear, it could be in both ears. The majority of the time, one ear, posterior canal. So it's important to understand that a Dix Hallpike only looks at a posterior canal. When we are evaluating for BPPV, we have to look at all three canals in both ears. So we basically have to evaluate 6 canals to be thoroughly comprehensive. Let's first look at posterior canal. So you have to understand, we're not using surgery, we're not using drugs to treat BPPV. We're using gravity. That's it. The otoconia is heavier than the fluid it resides in. In order to remove it from the involved canal, we simply have to make sure that canal goes into a gravity-dependent position. So, when you are evaluating and treating the posterior canal, we need to make sure that the top of the ear is lower than the earlobe. So we're going to use the patient's ear as a guide to where the semicircular canal is inside the skull. All right. So we're going to use a modified hole pike. We're not going to extend the head beyond the end of the table. This avoids any issues of vertebral artery dissection. This is what we call fully supported. The patient is going to use their upper body strength to hold on to the technician arm. We don't need to use video goggles. We're going to lift the head before we raise them so you don't have an orthostasis. We're going to do this on both sides. However, not everyone can bend at the waist because of large abdominal mass, lower back pains, so we like to use a side lying position. Now, also please understand, every assessment protocol we're using is actually position 1 of a treatment. So, if you wish to go immediately into a treatment from an assessment, you actually could. I prefer to get a full evaluation of both ears and of all the canals before I come up with a plan of care and actually go into treatment. But you could move directly into this. Side lying positions, very comfortable because it mimics what somebody does just getting into bed. We want the test ear to be the undermost ear. You can see the patient's ear. The top of the ear is lower than the lobe. If you notice, we make sure we swing their legs up onto the bed. This is important to avoid any hip or pelvis discomfort. So it's just like putting the patient in bed. Then we simply help the patient up. Here's an actual patient and the BPPV. We're going to look at the contralateral eye. If you have trouble seeing the person's eye, just simply raise their lid. Remember, BPPV nystagmus is mechanical. It will not suppress with vision or light. So you don't need any technology to diagnose and treat these patients. So what are the different treatments? Regardless of what technique you use, guess what? They all do the same thing. They progress the otoconia debris through the posterior canal till it dumps back into the utricle. Now, the otoconia are dead. They're not going to reattach to the macula. They don't go back to work. They go back into the utricle to dissolve. The solution for pollution is dilution. So the ratio of debris to liquid in a canal is not great enough to dissolve the calcium carbonate, right? So they have to go into the much larger utricle where the otoconia over hours will dissolve. Now, it doesn't really matter what treatment you use. They all work. They all work. But here's a caveat. Some treatments have a higher propensity for the debris to migrate into other canals. Some methods have a higher recurrence rate, but most importantly is the physical limitations of the patient. So the reason you select a treatment method is based on what is going to be the most comfortable for the physical condition of the patient. So it's absolutely patient-centered treatment. Now, this is a modified repositioning. Again, we're going to use the same technique, right? Now, this is a 3-step treatment. It has a higher propensity for horizontal canal migration. This is not typically our treatment of choice. We prefer a 2-step method. We're going to use the pillow to help roll the patient. We always do a little head shake. So if there's any otoconia clinging to the membrane of the canal, just like shaking leaves on a tree, and the patient is brought upright. Let's look at a Semont liberatory maneuver. The Semont liberatory maneuver is easy to treat in bed. Here's the caveat. You have to be able to comfortably and smoothly move the patient to the opposite side. So it depends on a certain degree of mobility. What are the advantages? The patient doesn't have to bend at the waist, and there's a lower incidence of horizontal migration. Now, let's look at a treatment we developed over 20 years ago called the Ganz repositioning maneuver. The benefit of this is it's a hybrid. So we can use a side lying. So again, it's like laying the patient in bed. But unlike the Semont, we don't have to have a big movement to the other side. We're simply going to roll the patient over in bed. So it's a 2-step. The patient is never on their back, and there's a much lower incidence of horizontal canal migration. Now, for patients with mobility issues, or if you want greater control, we like to use a towel or a bed sheet. Now, this is a very large model. This gentleman is quite tall. But you're going to see how we use the bed sheet or a towel. We find that patients also like this, especially older adults, because it swaddles them and they feel quite comfortable. Also, you have complete control of the patient. If you're a small clinician and it's a large patient, it's quite an easy movement. You see that. Very low probability of horizontal migration, and the patient likes the swaddling nature. There have been dozens of publications globally about the efficacy of the Ganz repositioning treatment compared to Epley, Semont's, and it's found to be equally as efficient, but without some of the contraindications like vertebral artery dissection with the Epley style head hanging, and also the much lower incidence of the horizontal migration. Now, why do you want to avoid horizontal migration? Because The vertigo created by debris in a horizontal canal is severe, much more severe than posterior canal. And if the treatment is going to bring a patient to emesis, it's usually going to be from the horizontal canal involvement. Now, remember, as we said, everything with BPPV is gravity provoked. So if you remember Ewald's law about semicircular canal function, the canal is finely tuned in the plane in which it lies. So posterior and anterior canals are vertical canals. So we have to be in a vertical position to trigger the response. The horizontal canals are just that, horizontal. So we have to get the horizontal canal in a gravity-dependent position. Now, unlike posterior or anterior canal BPPV, which always beats in one direction, right? So the posterior canal nystagmus always is an upbeat. Anterior canal is always downbeat. Not with horizontal canal. Because remember, the arm of the horizontal canal can actually point in either direction. So it could be geotropic, beating towards the involved ear, which is referred to as a canalolithiasis, or it could be beating away from the affected ear, or agiotropic, which we call cupulolithiasis. So our treatment, as you can see on this logic tree, may be affected by whether the nystagmus is geotropic or agiotropic. So let's take a look. Now, if you notice, we're tilting the head to put about 20 degrees to put the horizontal canals in a more horizontal plane. Because if you recall, the horizontal canal is a little bit higher in the anterior position. Again, we do the same thing on the opposite side. Now we can do modified treatments. This is a modified roll test. So when you're evaluating BPPV, although 90% of the time it's going to be in the posterior canal, don't forget to look at the other canals. So you're going to need to use different assessment tools for the different canals. Again, modified roll test. This is lateral body positioning. I actually prefer lateral. I like to get the patient in the exact or as precise a position as possible for the ear and the canal I'm evaluating. I don't like to contaminate my assessment by moving the patient from one position to another. I would rather have them in these very discrete positions. Does it take maybe a little bit longer? But it's only seconds, and I believe it's worthwhile. Now, here is a patient with a geotropic nystagmus, which means it's beating towards the involved ear, towards the ground. See, the fast phase is towards the ground. See, you don't need a video goggle to see this. You can lift the patient's eyes. Now, here's an example of agiotropic. This is a good one. See, the fast phase is away from the ground. So let's look at the treatment methods. So here's a hybrid method that we developed, which can treat either. So if you don't want to worry about the logic tree and figuring out what you have, you could use this hybrid maneuver, which has proven to be highly effective. And it basically kind of uses or combines an Appiani with a Cassani, but while the patient is in the same position. So the patient is comfortable and we just move them. This is the one exception because this is a treatment, right? So the hybrid method really does the trick and is much more comfortable for the patient because they don't have to go through a lot of different steps. Because remember, every time you're treating them, you're going to provoke the vertigo. So the less you provoke the vertigo, the happier the patient. So we can look at Appiani and Cassanis, which basically work to put the patient's head either down or up. Patient's head is down. Now here's a barbecue roll Lempert maneuver. This was one of the first treatments utilized. We don't use it, but it's available to you. Why don't we use it? If the patient is going to become ill, it's going to be from this treatment because there's two aspects of it. There's the vertigo induced by putting the patient in a gravity-dependent position, and also you've got some velocity storage mechanism. Also, you may have a mobility issue, right? For a larger patient, they may not be able to roll easily or comfortably. What about the anterior canal? This is not common because when you think about it, the anterior canal, the superior canal, how would it hold debris? Gravity always works. Gravity always wins. But if the debris is clinging to the membranous labyrinth, like sand clinging to a blanket, it's possible, or the cupula, it could occur. Rare, but it could happen. So if you look at the studies that have looked at the incidence of BPPV within canals, you'll see that the anterior canal is quite low. That's been our clinical experience as well. This is a good graphic from Califano that shows the process of using the deep head hang to evaluate and treat for anterior canal. Now, who is this contraindicated for? Well, if you have a patient that has a cervical spine issue, particularly maybe a vertebral fusion of C4 or C5, you certainly wouldn't want to do this. Anybody that you suspect with vertebral artery concerns. So you have to be very, very mindful of any contraindications to this condition. This is a deep head hanging put forward by Iacovino that is very successful in treating the anterior canal. Again, how do you distinguish between all of these forms of BPPV? Well, remember, posterior canal, right, when you're doing modified Dix-Hallpikes, right, is going to have an upbeat torsional, right? The anterior canal will have a downbeat torsional when you do the deep head hanging. Horizontal canals will have a horizontal nystagmus, either geotropic or ageotropic. So the nystagmus is always going to point you in the right direction. You just have to be knowledgeable enough to be able to discern the fast phase of the nystagmus. Now, again, as I mentioned, what are the precautions for the deep head hanging? It's contraindicated for cervical or thoracic spine comorbidities, and if the patient has any kind of abdominal or lower back problems that does not allow them to get into bending at the waist. Now, you could kind of manage this in a side lying, but it's a little bit more difficult. Now, what about restrictions? Well, the data is very, very clear for many, many years that restrictions are not necessary. They're just simply not. Now, we don't recommend that the patient get out of a treatment and goes and lays down immediately. We don't recommend that they go do yoga or a Pilates, but the reality of it is that sleeping upright for 1 or 2 nights or using a cervical collar like we did for many years is not necessary. Lots of data and research, including data that we did 20 years ago. So, what is our protocol? Simply not necessary for restrictions. But, if we have a patient that does recur, we do use some restrictions. Now remember, the otoconia is calcium carbonate. If you have a patient with significant vitamin D deficiencies, when the otoconia goes into the utricle, then the otoconia may not dissolve as readily as with patients who do not have hypovitaminosis of vitamin D. So for those patients, we are going to suggest that for at least one night, they sleep elevated at least 30 degrees, right? And then avoid sleeping on their side for 2 to 3 nights. Why avoid sleeping on the side? Horizontal migration. Horizontal migration. So, are there any complications? And the answer is yes. A canalith jam, where the debris actually gets lodged in the common crew, right? This will cause ongoing vertigo, must be treated immediately. How do you treat it? You merely reverse it and let the debris dump back into the utricle. This will be a failed treatment. You can try it again with them, but unlikely that the debris will fall through the common crew. The second is a Tamarkin crisis. Unlike the Canalith jam, which indicates a failed treatment, this indicates a successful treatment. The belief is that the debris is falling back into the utricle and either causes a vortex or lands on the macula, and the patient will have a whole body response with a hallucination that they're falling. Hold on to the patient, protect them, but it means that the treatment is successful. The third condition is a horizontal migration. It means the treatment got the debris out of the posterior canal, but instead of going back into the utricle, it took a side cut into the horizontal canal. At that point, you have to evaluate and treat the canal. You have to treat that horizontal canal. So here is our exact protocol. If you're checking for the posterior canal first, which makes the most sense, treat the affected posterior canal. With the patient still there, wait 3 to 5 minutes. Recheck the ear you just tested. Do not worry. You will not put the debris back if it was successful. If it is still positive, retreat them. Now, remember what Einstein said. Insanity is doing the same thing over and over again, but expecting a different outcome. If you used a Semont maneuver and it was unsuccessful on the first treatment, go to a modified Epley. Go to a Gans repositioning. If you use the Gans repositioning and that didn't work on the first treatment, when I say first treatment, I mean right then and there, then go to a modified Semont. But there's no reason to have the patient go home with active condition. Once you've successfully cleared the canal, then you want to make sure that you evaluate the horizontal canals. You don't want to successfully treat a posterior canal, but unknowingly send the patient home with a horizontal canal BPPV. That would be horrible, because they're going to call you frantic. What have you done to me? My vertigo is worse. So always send the patient home knowing that all of the treatments are successful. So here's a full evaluation treatment. So we're treating, here this is a Semont maneuver as an example. Full progression. Again, you can see the patient has to be able to make that swing from side to side. Then we wait about a minute in each position and put the head down so any debris can drop. So, I want to thank you for this time we've spent together. And again, thank you, Dr. Neha and her great team at AIB India. You are near and dear to our hearts.
Sir, thank you for joining us, and it was an excellent session on BPPV and beyond, and the different modalities that we use, especially when we don't want to compromise the spine or the patient coming with pain. So, an excellent session by you once again, sir. Sir, we are going through the panel discussion right now, just within in few minutes. So, I would just request all my speakers to just come back on the panel, Dr. Vikram Khanna, sir, and Dr. Lakshmi Patil, so that we can start off with the panel right away. So we have few questions, and And we are currently having an audience of more than 750 currently that we have. Of course, when we reach it out more, we expect it to be the numbers to rise further, and this is getting an international validity right now. So there are many people from across the different part of the world who are watching us right now. So here are a few questions by some doctors. So basically, there is a question that what is the minimum setup required to assess a positional vertigo in a rural population? So, Dr. Gan sir and Dr. Vikram Khanna sir, please give your expertise on this.
I would like to speak first because, sir will correct whatever wrong I'm saying. So I think what you need is a spacious consulting room with an examination cot where the there is space on both the ends of the examination cot, and there is some space behind the examination cot also, so that you can do the maneuver and the head hanging test and all on that single cot. And you need a simple mobile camera to see the nystagmus. You don't even need those fancy glasses or something. A good history, basic clinical examination, proper Dix hike maneuver, I think is more than enough. I stand to be corrected by.
Sir, you can please proceed now.
Dr. Khanna, you're much too generous. Well, yes. There's also, so just remember, to don't just evaluate well, let me stop. Two types of patients: the dizzy, vertigo patient, the imbalanced patient. An imbalanced patient may never have a report dizziness or vertigo. Let's deal with that patient first. The balanced patient then has to be looked at within their biological age. Is this a younger person that has a sudden onset of imbalance? Or is it an older person that is noticing some falls and that their balance is deteriorating? There are standardized tests that require no equipment. There's what is called the timed up and go test, where you can simply have the patient stand out of a chair, walk so many meters, and turn and come back to you. There are limits of stability tests that have age norms. There's single leg stance. So you have standardized tests. You don't need electricity. You don't need a computer. They've been standardized. You can download these and you can get that information. You can also use patient clinometrics. There are scales like the Dizziness Handicap Inventory that are easily used. There are short forms, but again, that's more for dizziness, not just general balance. When you get into the dizziness, I would look at using a paper and pencil screening test. You have the patient do this in their waiting room when they're filling out their paperwork. It can be very, very helpful. Remember, the majority of patients that are coming in are going to have BPPV. Makes your life much easier. But a significant amount of the BPPV patients have comorbidities. They've had vestibular neuritis. They are perhaps on the spectrum with Meniere's. They're on the spectrum of some point with migraine. So they're much more complicated. So as you've heard over and over from the other speakers, the case history. Is this sudden? Does it happen with changes in gravity? Are there any precipitating factors? Now, having said that, while BPPV nystagmus does not require equipment, goggles, does not suppress with light or vision, most other forms of nystagmus will be diminished or obliterated by vision and light. So if it is at all possible to have an inexpensive video goggle, I don't know what's available in India, but I know there's a wide variety of excellent technology that is relatively inexpensive, at least by US standards. That would be wonderful to have something like that. But for the most part, you don't need a lot.
Okay, Dr. Lakshmi, you want to add on to this? So the question was when we started that what all do we require in a peripheral setup for positional vertigo evaluation? So we are just talking about a setup that is required for evaluation of a vertigo.
So even I agree with Dr. Richard. We don't really require very fancy equipments. A good history, a good clinical examination, and the practice of doing it. The what problem is we can attend to conferences, we can learn the maneuvers, but more and more we do it is what will get us more confident in doing it. That's the whole thing. Because even if you have a video of it and you are not doubtful of interpreting it, it's not going to help you. So it's about more experiencing and building up your own case series. That's going to help.
And the more you practice, the more you become steady and you more enlighten yourself. So basically the thing is that even when you start with even evaluation or basic evaluation, as an ENT, we start with the ENT examination, we do the tuning fork test, then we go for the balance examination like doing Romberg's, Unterberg's, Hens evaluation, and then we step forwards towards BPPV. But before you touch the patient for BPPV, always check for the neck rotation axis, because sometimes you may never know that the pain that may be coming may compress the vertebral artery and there will be a number of complications. So it is better to avoid, first thing, the patient with a neck pain, do the other exercises that the supportive method which sir has already shown. The second being, the patient should be off any kind of vestibular suppressant or the vestibular drugs, because they may mask your nystagmus in BPPV very commonly, especially in higher doses. All the four drugs are quite competent enough to mask your BPPV, so you need to step down or maybe taper down the drug. Third, you must also be able to assess the postural stability, very commonly seen with the Parkinson-inducing drugs, very commonly that we use in India, because there's an excessive use of medications here. And the excessive drug history that we take, along with the hypertension or diabetes, or maybe the usage of a calcium channel blocker group, which has been used for hypertension, the similar being used as a vestibular suppressant also will add on to your further complications, and give a masking effect, maybe a drop in a BP, or a patient just presenting with orthostatic hypertension who may be actually having a BPPV. So basically there's masking of the symptoms. So you need to clear one by one. So the best is to just remove the vestibular suppressants at this point of time and go with
Yes.
the flow of the patient and explain the patient the risk for the next 3 to 4 days until the patient comes back to you for a follow-up. So this will be my message, especially on this particular question. I hope my guru agrees with what I am saying today, and he is there to assess me and give me marks. Yes, sir. So Gyan sir will tell me that whether I am right or wrong.
What can I say? The student has surpassed the teacher.
Sir, thank you so much.
Neha,
So
one
this
more
is
thing I would like to add. Am I audible?
Yeah. Please, sir, go ahead.
Yeah, I think even though we are ENT surgeons, but whenever there is a patient of vertigo, especially middle age or old age, we must check the pulse for a full 1 minute and take the blood pressure ourselves.
Yeah, very true, sir. Very true. So basically, yeah. So please go ahead. Please go ahead.
I want to acknowledge what Dr. Khanna did in his presentation.
Yeah.
Rarely have I seen a 3PD presentation that even touched on prevention.
Yeah.
So that was excellent, because 3PD doesn't just appear. I refer to it as a spectrum disorder. And you can see years before it manifests to that level, behaviors, avoidance, oh, I can't do that. I don't like that. I don't go out on the street because the movement bothered. They begin. So what Dr. Khanna presented was really very, very good for clinicians to really listen to patients years before they actually evolve to a full-blown 3PD. They will begin to demonstrate and report these little pieces on the spectrum that they're headed in that direction. So I want to commend you, Dr. Khanna, for bringing that up.
Thank you very much, sir.
So now the next question is that please discuss the treatment of Meniere's disease and migraine in same patient. So, Dr. Lakshmi, you can start with it because we are touching on migraine, and so you can start with your central vertigo, which comes from, of course,
Yeah.
migraine-induced vertigo, and then we step on to Meniere's. Yes.
Yes, I need your help to treat the manias though. Yeah, so for migraine, it is like any other migraine. So you don't have to really treat it with the vestibular suppressants, but you treat the core migraines. I prefer personally using the calcium channel blockers like flunarizine, use propranolol, and SOS migraine trigger medications that we use like rizatriptan if there is a headache involved. And if the vertiginous sensation is really, really bad, they can't really maneuver through it, then I ask them to take a bit of beta histidine, if at all, and try to identify the triggers. So the treatment of vertiginous migraine will be in line of treating like any other migraines, though the symptoms look different. So what are the triggers? Trigger management is very important. Early identification of symptom and taking the SOS medications on time is very important. And prophylactic medications for a certain amount of time is very important in this. And so menias, what would you do if the menias are in along with it, Dr. Neha?
Vikram Khanna, sir, you want to add on to the Meniere's question?
Well, the treatment for Meniere's is more or less standard, which we ENT surgeons are taught at our MS level. But in such a patient, I would never treat that patient alone. I would always team up with my neurology colleague and we would treat together. It saves the patient time and multiple visits. So either I would go to his clinic or he would come to my clinic and we see this patient together and treat the patient so that patient not only receive short-term symptomatic relief, but we also prevent relapses for both the diseases.
Great, great.
So you want to add on to this Meniere's migraine spectrum? Richard, sir? Yeah.
Interesting. What we have found in our postmenopausal migraine patients is that if they are postmenopausal, secondary to hysterectomy, and they have been given hormone replacement therapy. I don't know if this is a common practice in India, but it's fairly common here. We have seen the imbalance between estrogen and progesterone be a huge trigger for acute onset vertigo. And so we actually, in addition to the ENT and neurologist, we have embraced gynecologist because we have found that oftentimes we've got a severe and abrupt hormonal dysfunction with progesterone levels too low, and that has been the trigger. And when the progesterone levels are increased, the acute vertigo episodes abate. I don't know what your experience has been with this.
So based on that same paper, I have been following up in India, based on the hormone replacement or maybe the use of more IVF clinics coming up with more steroid usage in India because of the low AMH level. There has been quite a certain number of population who have been showing a good hormonal imbalance in the gynecological practice. And of course, thyroid, the TSH levels or the autoimmune thyroiditis has been also very key component. If you see in these cases, the people will generally come with diabetes or blood pressure, but they will not address their TSH, which may be a borderline or maybe a subclinical hormonal imbalance, which may have some internal correlation to have with BPPV mechanism since the calcium metabolism is involved. So I commonly like getting, of course, following the AIB spectrum, I have seen this very commonly in my practice. Secondly, there has been a lot of the stresses factors, less sleep, competitive market, peer pressures. So that has also led to a rise in the number of migraine cases. But the only thing is that when you start differentiating migraine with menias, you have to have the audiogram very much handy to just clarify as to actually you have a hearing loss, there's a block sensation that you feel secondary to migraine. So audiogram, PTA becomes the main mandatory standards, if you want to differentiate. Of course, if the patient is having a gradual decreased hearing loss, and I believe, sir, in your last lecture about 1.5 years back, you just told us that after 7 years, menias turn to burnout, I believe, and migraine is something that may stay with the patient in such cases. So this is how this has been the, like, if you map the disease spectrum, then it goes like this. So basically, the symptoms
Yes.
comes to us first. Maybe if it's Meniere's projecting, so we add a diuretic, be it Diamox or acetozolamides, or it can be even chlorthalidone, weak diuretic, based on the patient compliance and of course the other comorbid medications they are taking, or it will be just be the anti-migraine therapy that may also do wonders, based on
Yeah.
this with
And
chemotherapy.
anecdotally, migrainers, according to a wide variety of investigators, migrainers may have 3 to 4 times the incidence of Meniere's than the general population. So, and then if you have diabetes, I mean, the comorbidities, as one of my great professors used to say, the human body is a bag of seawater with a hole at each end. So, thinking that any of these conditions can just reside in isolation is really naive.
Okay, so we have
So,
one more
sir,
question. Yeah.
Professor Gans, I learned something new from you today, that both Meniere's disease and marriage both have a 7-year itch.
No, but,
Yeah,
sir, but one thing, but I heard in Swiss it is saying 7 years you make it or break it. So Meniere's will break after 7 years. Marriage we can't
yeah,
say, it depends.
yeah. But
But marriage is
Meniere's
also
disease
referred as
may,
migraine.
yeah,
Marriage,
Meniere's might be a little less expensive than ex-wives or husbands. I don't know.
sir, wives are also called as migraine because many husbands refer them as headache. So, one time I called my friend, I said, "How's your headache?" He said, "My headache has got a headache," and it was migraine.
Okay, so there's one more question coming up. So basically, the question has been framed as in paralytic and hyperactivity of labyrinth, where is the nystagmus fast component directed to? So basically, the paralytic is what this is talking about is maybe a unilateral vestibular hypofunctioning and hyperstimulation. So I'll just reframe the question again. In paralytic and hyperactivity of labyrinth, where is the nystagmus fast component directed to? So basically, in unilateral vestibular dysfunction or there is an hyperfunction, it will be directed to the opposite side. So if the right ear is affected, the nystagmus will be towards the left, and the hyperactivity will be on the same side, because that's the answer for the same. The reason is the right ears, the eyeballs move towards, when we move to the head is turned to the left, the stimulation of the right labyrinth, and the vice versa. So when any of this has a firing or a decrease, that the nystagmus gets deviated on the other side. Sir, I think you can explain it in a much better fashion, Richard Ganser, as to how does it come up. Basically, they want to know the pathophysiology of vestibular ocular reflex and how does it work, and the nystagmus.
Yeah. So Ewald's laws, right? Excitation is greater than inhibition. So what happens is that when you have an acquired labyrinthine dysfunction, the involved ear, like a battery, loses the voltage. The brain sees that and is going to beat slow phase to the sick ear, fast phase to the stronger ear. Now, interestingly, after vestibular neuritis, for example, or even a Meniere's attack, because remember, all labyrinthine disorders are destructive. There's no labyrinthine disease that causes an ear to hyper. Now, that's not the case with BPPV, because remember, BPPV activates. But if you're talking about Meniere's, vestibular neuritis, they're destructive. So they're always going to cause this. But they usually don't stay here, do they? They start to recover at some point. Now, there is something called recovery nystagmus. So you may see the patient on day 1, and the nystagmus, slow phase to the sick ear, fast phase to the stronger ear. Now, the sick ear is getting better. You see them on day 4 or 5. Now, the nystagmus is beating towards what looked like the sick ear. And you think, oh my, is this the direction changing? Is this a brain? No, it's recovery nystagmus.
So, Dr. Lakshmi, want to add anything on this?
No, Dr. Gans has explained it in more detail and this explained it very well. Nothing to add here.
Okay. So only 2 more questions that I'll be taking. One is how to diagnose vestibular neuritis. That is what is the clinical. Clinically, how can you diagnose vestibular neuritis? And second is, does BPPV relapse? So only 2 questions for this day. So one is, does BPPV relapse? And other is how to diagnose vestibular neuritis clinically.
So vestibular neuritis is a very, very classical symptom. Patient will have very acute onset, persistent vestibular symptoms of vertigo, nausea, vomiting, and it's a very dramatic. Patient is looks very sick. I have recently had a patient who just kept his eyes closed and didn't want to come out of the bed because of the intense vertigo and vomiting he was experiencing, which started acutely, and it's persistent. So it may aggravate by changing position, but there is a constant symptomatology that goes in the background. And like we discussed earlier in the lecture, you try to do the hints test, head impulse test, which will give you a reassurance that this is peripheral in origin, a peripheral type of nystagmus, that it is beating to the opposite side compared to the side affected. So if it's the right side that is affected, the fast beating nystagmus to the left. But in having said that, as a neurologist, though I'm very certain of my clinical thing, I will still do an MRI brain to rule out that there's no acute stroke. And I'll be reassured that there is no stroke here. And sorry, just one point. I try using short course of steroids in this and it works. So I just wanted to have others panelist opinions on this.
Can I say something?
Yes, sir, please.
Well, vestibular neuritis is not a difficult clinical diagnosis, provided you put your head into it. So you need to take a proper history and do the basic tests, at the most an audiometry. And the diagnosis is there in front of you. I would never do an MRI to establish vestibular neuritis unless there is some clear-cut neurological deficit which has coincided with the onset of giddiness. Second, BPPV can relapse. Yes, if it occurred for the first time, it can always occur for a second time. There are 6 canals. Any canal can be involved. We can treat that particular episode of BPPV, but a relapse is definitely possible, and we have seen in many cases that it has occurred. The etiopathogenesis may not be the same every time because it is a multifocal But yes, it is treatable as it was in the first episode. The second episode can also be treated. The third episode can be treated. I'm talking about the relapse episode. So for ENT surgeons, I think diagnosing vestibular neuritis does not require any, it can be done in OPD basis. Even a good tuning fork test can tell you whether there is hearing loss or not. You do the whisper test, voice test, and that is enough. You don't need an audiogram also, unlike in many years. This is what I want to say, and Professor will correct me and Lakshmi both.
Sir, please give your inputs.
Let's talk about recurrence. Let's define recurrence. I don't consider a recurrence anything less than 30 days. You probably didn't really treat the patient thoroughly. That's reality. That's why our protocol is to be sure that you recheck, retreat the patient, check the horizontal canals before you kiss them goodbye. Otherwise, you don't, hope is not a strategy. I did something to you, I hope it worked. No, you check the patient. Now, recurrence. There are several populations that are more likely to recur. Migraine, diabetics, head trauma, and patients with undiagnosed, untreated vitamin D hypovitamintosis. Those are the four main populations that may more likely to recur. Now, very often, patients say, well, please, doctor, tell me, what can I do to make sure it doesn't recur? One, you could pray. But what I might recommend is if you do have low vitamin D levels, make sure you're following your pharmacist, your physician's recommendations for vitamin D supplementation. The other thing you can do is empty the wastebasket before it gets full. Now, I don't recommend self-treatment of BPPV, but if the patient is prone to recurrence, when they are asymptomatic, I would like them to do a simple Samant maneuver treatment, maybe once a day, 3 times a week. Empty the basket before it gets full. And those are some of the strategies that I would recommend.
Sir, also your point on vestibular neuritis, if you want to add on, like how to diagnose vestibular neuritis?
I'm just a dumb old PhD. You're the physicians, that's your job.
Okay. So there is a slight difference between vestibular neuritis and labyrinthitis. So basically, labyrinthitis involves your hearing, and vestibular neuritis involves the superior vestibular nerve. So when you are having a case of vestibular neuritis, as what Dr. Lakshmi has mentioned, I would have also gone with the same protocol in an attempt to just get rid of the pica stroke that may be impending. Correct me, Dr. Lakshmi, if I go wrong on this, that there may be a possibility that there may be the patient may be having, even though we get, because there's something known as pseudonystagmus also,
Exactly.
pseudopharynx
That's the
that we may
reason.
be experiencing in a case of neuritis. I will just share a recent case. A patient came to me after 15-20 days of a recent vertigo. He was on suppressants. The only history he told me in the entire clinical battery which I did, the only history was told me, doctor, when I was doing this movement, I was jumping jack movement, I had a blackout. I immediately, that blackout story didn't go well with my peripheral vertigo story, which was more of this neuritis kind, which was coming up again and again. He had gone to a cardiologist on that day, that particular day, but he never did his neuro evaluation. To that point, I asked my neurologist, Dr. Dinesh Singh, to have a look. I and Dr. Dinesh Singh called me up saying, Neha, it looks very much like a neuritis. Remember, doctor, there is a slight gap in this. I would like to do this MRI of this patient. He had a clogged vertebral artery. He was having a stroke. So basically,
So
it is prevention is better than cure. Also says that radiology evaluation is not against your clinical. This is an add-on. You can always add to it. So
yeah.
consider I would have gone with Dr. Lakshmi has
No,
told.
why I'll tell you
This.
this, while I was preparing for this lecture, I
Hmm.
came across a very nice paper by, I don't remember the name of the professor, who has a whole series of multiple patients presenting like a peripheral vertigo, but all had an essential etiology. It may
Hmm.
be a very lacunar infarct in the eighth nerve apparatus, a very tiny ischemia, somewhere which was picked up, and they had to repeat the MRI after 48 to 70 hours to prove that.
Yeah.
There were certain things. So there's good case series of this. So yes, the clinicians, we know where we are headed, but at today's time when everything is available, everything can be done, we should also take the assistance to prove that nothing is wrong, because the clinical practice is becoming also medico legal, so you have to
True.
be right at times. So
Very
any
true.
hint of your history which is telling no, this is not fitting into the right picture like you did, I think then it there is no harm in doing an extra test, according to me.
Because he had an abnormal BP, he was an alcoholic, and when he was having this jumping jack movement, he had a blackout which didn't fit my peripheral vertigo checklist.
Exactly.
And that is what made me more curious to understand that what was has been happening since this. So this was just one of the cases, but out of the 10 that you see, 8 will go by your clinical judgment, but that 2 may be one of those which may not
Exactly.
fall in your normal
No,
category of testing. That
similarly,
is
I
the
saw a
thing.
patient whose history was similar to very acute vestibular. In fact, it was a retrospective diagnosis. He presented with acute onset. He's watching his phone and suddenly started to throw up, feeling vertigo, and felt that he was not able to walk. When I saw him in the emergency, he was just head down. I couldn't even do a full neurological examination. So symptomatic he was. And obviously, he was ataxic. I had to do the MRI. But next day, after giving him MRI, obviously was negative. But next day, when I had already started him on treatment, he was absolutely normal. So it became a retrospective diagnosis that it was a vestibular neuritis.
There
So,
was, yeah.
there are always outliers in the, normal
So
story.
there was one more case similar to this. So both were, say again in this case, the cardiologist had already evaluated, and actually it came down to become a neurological case. So atypical presentation, mixed presentations, and vertigo are very common, and holistic approach, multidisciplinary approach works very well when we stand in the case of vertigo. Sometimes an ENT will have to work with the diabetes to get down to diabetic control because of the recurrence rate. Sometimes we will have to work with an endocrine, sometimes with a neurological friend, sometimes with along with a psychiatrist, sometimes with a physiotherapy. So keep the spectrum and the arms open when you deal with vertigo, because vertigo is a very vast subject and there can be anything to counter that. With this, we will close the session for this day. I would like to thank first and foremost Dr. Richard Gast, sir, on a Saturday morning joining us from US. Sir, it is always a pleasure listening, learning, and having your experiences of 32 years, which AIB India carries with whole warmth. And we look forward to many more sessions with you this year, sir. Thank you so much. I would like to thank Dr. Vikram Khanna, sir. He has done an excellent job of that presentation of 3PD. Very few I have ever seen like this, with an extensive presentation. Excellent, sir. And Khanna sir was actually waiting to hear from you about his presentation, which I am sure Dr. Ganser has liked it. Dr. Lakshmi, always a pleasure having you on
Thank
the
you.
program, discussing more about the mixed forms, discussing about the approaching the case with lot of warmth, care, also being sometimes a good counselor to the patient, explaining them their disease prognosis and how things stand by, because you have to win
Yes.
a patient's trust before treating the vertigo. You're a healer, as sir has mentioned, and not a doctor sitting there, because you may be the last doctor he may be seeing before in his entire lifetime, probably, because he has changed so many number of doctors.
Yes,
Thank you,
yes.
Pinakin sir, for yet again being a very good host in the program. I think you must have also got a degree on vertigo by now, since the time you have been doing so much of webinars
Yes,
and a
it's
very
very,
vast
very
understanding,
enlightening.
very
Very,
vast
very
understanding of the
enlightening
subject.
and enriching.
Yeah. I would
Yeah.
like to thank my team at Doc Mode, especially Vinayak and Mamta for guiding us through, and Bala for supporting us in the entire program, and my team at AIB India. Our next session will be on 7th of March. Of course, we have a lot of academical courses which have already started. Our online courses are still running, and we are going to explore more this year. So you can log on to www.aibindia.com for more understanding. Over to you, Pinakin sir, for the closures, final closures.
Neha, before Pinakin starts and before we kiss goodbye to Richard Gans sir, uh, I would just add to what Dr. Lakshmi said, that my words were very specific. I said I would not hesitate to do an MRI if there is any neurological symptom or deficit that I encounter in the history which has its onset with the onset of the other symptoms of vertigo. So I
Yes.
stand
Yes,
corrected
sir.
there. I just wanted to point out. And
Well taken,
Yeah, yeah.
sir. Point taken very well, sir. Point taken.
It
Yeah.
is
thank you,
actually a very
Dr.
pleasure to hear,
Very
listen to Dr.
privileged.
Richard Gans and understand the vertigo in little more depth of it. Thanks for all this.
When you
Special
start
thanks
listening
to
to
Dr.
him, you will
Gans.
understand what is vertigo. And when I have heard so
No,
much from him,
when he was
and it is a
explaining in
different
the
spectrum.
panel discussion, you could actually visualize what he's trying to tell you, how things and mechanisms are working.
He
That's
sings
the fun.
vertigo basically. He sings it out in his fashion, like in a concert,
Yeah.
how they do a thing.
So
So, sir,
nowadays,
may you continue to inspire us as always and stay young forever.
nowadays, when we listen to Trump, we get vertigo. When we listen to Richard Gans, we feel relieved.
I may have to move to India.
No,
Most
please,
welcome,
sir.
sir.
Please continue.
It will be our
Most
pleasure.
welcome. Most welcome, sir.
Sir, you are not only in our hearts, but also in our homes. You will be most welcome anytime you come to India, sir.
Well, we're ready. We're ready.
We are ready, sir.
Special thanks to Dr. Gans, because in spite of a bad throat, I think you made a wonderful presentation, and I can imagine the kind of efforts it has taken you to speak with this, condition. But you have made it, and it was a wonderful session. Thank you once again. And lastly, I would like to thank our audience for being patient and for supporting this initiative. So thank you very much, and have a great day.
Thank you. Thank you so much.
Thank
Thank
you.
you.
Thank you. Bye.
Bye-bye.